in general. This unmet need is often referred to as the treatment gap. So to break this down further, consider this. India has only 3 psychiatrists per 1 million in the population, whereas in the US, a more highly resourced country, that's about 167 psychiatrists per 1 million population. Another way of looking at it is that India has about 25,000 total mental health healthcare workers at different stages of training for its entire population of 1.3 billion people. Here in the US, we have about 900,000 total mental health care workers for 300 million people. So if India's mental health workforce did nothing for a year except treat individuals in need of services for an hour every single workday of the week, more than 96% of its population would still not be able to access services. Youth face additional barriers to treatment in limited resource settings. So youth often have concerns about confidentiality. They lack knowledge about how to navigate healthcare treatment service delivery systems, and they may face logistical barriers to accessing treatment, such as transportation to get to appointments. Next slide, please. So there have been a number of strategies proposed to close this treatment gap. The first such strategy is task shifting or task sharing. So task sharing is an approach in which non-specialist providers or healthcare workers are trained to deliver psychosocial interventions with supervision from more experienced clinicians, such as psychologists or psychiatrists. Task sharing addresses this issue of a limited specialized workforce by scaling up people who can deliver treatment without needing to engage in extensive education or training programs. Although we still know that we need supervisors at a higher level to make sure that they're available to consult on particularly hard cases. Another strategy proposed to close the treatment gap is adapting and scaling up EBTs or evidence-based treatments that have been developed in Western settings. So the idea is that we know that EBTs work for the population here. Why don't we just take them to new settings and see if they can be used for youth in need there? There are some issues with this, however. We know that contexts vary considerably, not just between countries, but even within countries themselves. And there's a concern that if these treatments aren't significantly adapted, they won't fit the context and effectiveness will be compromised. And finally, there's another encouraging solution to the treatment gap problem. This involves building a treatment for a context within that context to increase fit without requiring significant adaptations to start over from scratch. So for example, Bruce Torpeda and colleagues, and Bruce is one of the people involved in building the Step 2 intervention that we'll be talking about today. He developed a toolkit for designing interventions called the Managing and Adapting Practice. So that basically uses different tools to fit a treatment's intended delivery setting in a different context and allows providers to individualize treatments for clients using evidence-based elements and systems of coordination. So there's compelling evidence that taking this sort of building and context approach to building treatments will increase fit with a context and then therefore increase the access and scalability. Next slide, please. So the research program that we'll be focusing on today is called PRIDE, which stands for Premium for Adolescents. And it's a research project aimed at developing youth mental health programming for Indian youth in schools. The primary aim is to develop a transdiagnostic or multi-problem stepped care intervention targeting the most common mental disorders in school-going adolescents in India. So the 3 most common mental health disorders that we identified through research in earlier phases of the treatment were depression, anxiety, and conduct problems. Next slide. So some key features of PRIDE that again are aimed at addressing that treatment gap we talked about earlier are that it's a stepped care intervention. So stepped care interventions help with the problem of low resource settings in that they offer 2 different levels of intensity to reach a maximum number of youth in need of services while reserving the more intensive treatments for people who have more severe problems. So PRIDE has step 1 and step 2. So step 1 is a brief 4 to 5 session, low intensity problem solving intervention. So that's intended for youth who have mild to moderate symptoms of the problems for which they are referred. And the hope is that problem solving as a skill can help them solve problems, whether it's related to anxiety, depression, or conduct. Youth who don't respond to step 1 of the treatment are referred up to step 2. This is a higher intensity, slightly longer, face-to-face psychological treatment that's not necessarily delivered by lay workers, but rather reserved for folks who have a training and background in mental health services. PRIDE is also multi-problem, which is another word for transdiagnostic. So this helps address the issue of a limited specialized workforce by identifying skills that have common applicability across different disorders. So for example, relaxation is one common element incorporated in this treatment because relaxation has been supported by research to be effective for problems with anxiety, depression, and conduct problems. Therefore, we can train providers to deliver a limited number of skills, but reach a maximum number of youth coping with problems related to their disorders. Next slide, please. So PRIDE is being tested in 2 sites in India. The first site is Goa, which is a state on the west coast of India. It's small yet highly urbanized, and we were working there in parochial schools. So these were government-funded schools that had a religious affiliation. And then we also are testing PRIDE in Delhi, which is really different from the Goan context. Delhi's a mega city. You can even see in these 2 pictures, they're very, very different places. And the hope was that if we could demonstrate that PRIDE was effective for youth across these very different settings, there is potential to scale it up across the country. India is incredibly diverse, which makes it wonderful. And also it adds to the complications of fitting a treatment to context. So we thought, if it works in both of these, maybe it'll work elsewhere in the country. Okay, next slide. Here are just a couple of pictures to give you an idea. I conducted this research in India, in Goa, for my dissertation. And this is just to show you kind of what it was like. Here's one of the schools. Here's another school. You can see that church in the background. Here's a room where I actually delivered services to youth. So it's pretty bare bones, but I mean, you have the coconut trees outside, so that was nice. And then we had a counseling drop box, and this is for youth to refer themselves to services without having to necessarily talk to a counselor or a teacher if they were experiencing a problem. So we identified a number of design objectives for building this intervention. We wanted it to be something that could address, again, the 3 problems identified as most pertinent to youth in this population. So it had to have that multi-problem transdiagnostic focus. We want it to be efficient to learn for providers and efficient for them to deliver within a limited clinical encounter. So again, this is a school-based treatment and we couldn't be pulling students out of class for an hour. We really were looking at 25 to 35-minute sessions to fit within the school day. We wanted step 2 to be appropriate for a workforce with varied backgrounds. So we wanted to see, is this something that folks who don't have a background in mental health can learn and deliver? And similarly, is this something that someone with a more specialized degree, like a master's or PhD, could they also deliver it and feel like they were being effective? Again, we wanted it to be delivered within a set number of sessions. We didn't want this treatment to go on, and it had to fit within the stepped care model. So it had to still relate and be an easy continuation from step 1 of the step care intervention. We also thought a lot about kind of the interface of the protocol, so its look and feel. Again, we wanted it to be very engaging for youth, so it needed to be culturally appropriate, culturally responsive, intuitive and suitable for the counselors using it, engaging for youth, accessible for youth with varying levels of literacy. And we wanted to, as much as possible, reduce barriers to implementation, first identifying what those were and then figuring out how to reduce them. Next slide. So this is just, I'm going to briefly kind of guide you through some of the intervention materials that we ended up developing. There were some for therapists, like a manual, a flip book, ways to record what was going on in an event sheet, and then student-facing materials that were handouts, illustrations, and progress monitoring tools that we wanted, again, youth to be involved in using so that they could track their progress and be engaged in the treatment. We designed all of these materials in collaboration with the team in India. There was a lot of iteration, a back and forth process of, talking about everything from, is the skin color going to be something that's acceptable to youth and providers in different settings, and the illustrations to how much text is too much text. So there was a lot of back and forth in the design process to make it be as accepting, engaging, and effective as possible. So I'll just show you, this is the provider-facing manual for one of the modules. Providers expressed a preference for keeping it to a one-page sheet early on in the intervention development process, and they wanted to have certain icons that would be easy access for them to glance at and remember what came next in the session flow. Next, you can see the overall flow of the treatment. So this is what providers use to plan treatment. We all, again, started with common elements modules that were truly going to be effective across problem types. So psychoed and engagement and relaxation. And then folks branched off into more specific behavioral skills depending on their problem type. We had a couple of other optional modules depending on how they responded to the behavioral skills. And then everyone wrapped up with maintenance and termination. This is what youth saw. So the previous slide was what providers saw to help guide them through the flow of treatment. And this is what youth saw. So this is how we introduce youth to the treatment and let them know the roadmap for what lay ahead. We also had a flip book for providers. This is a distilled down version of the manual. And the idea was that as providers gained familiarity with delivering the treatment, they wouldn't necessarily need to look at the full manual and read scripts. They would become more familiar and able to glance at this and say, okay, I know what to do. I'm feeling confident in my abilities to deliver treatment. This is just a reminder. And on the other side of that was the flip book page that a student would see. So we had some illustrations. And again, these were largely developed by the India team based on their previous experience with the population and earlier phases of PRIDE research. There were also handouts for youth to take home for in-between session practice, homework, although we tried not to call it that. And then we had some progress monitoring tools. And so we kind of tried out a few different things to see, what did youth enjoy reporting on their mood? Did they like something like this, or did they like something like in the next slide? We asked youth about their top problems, and we tried to incorporate visuals as much as possible. So using a bar graph so students could actually see that their problem was coming down. We did have them complete the SDQ, the Strengths and Difficulties questionnaire as well, but we also were trying to see how can we reduce burden on students and not give them 3-4 progress monitoring tools, which is going to be the best. So a lot of this was exploratory, and these were the building blocks for a randomized control trial later on down the line. So engagement, we've been talking about how this intervention was designed to fit with the context, to be engaging to youth. And we're doing this because we know that poor engagement in children's mental health treatment is a concern, and it has been for quite some time. So up to 50% of youth in need of services do not enter treatment. And among those who do begin treatment, the majority terminates prematurely. So before they've derived full clinical benefit of treatment, they drop out for various reasons. And we know that there's an association between poor engagement and worse treatment outcomes. So improving youth engagement in treatments really should be a priority when we're thinking about helping youth in need. However, it can be difficult to measure engagement in treatment. So largely, attendance has been the primary metric of engagement measurement in mental health treatment studies. Unfortunately, by the time people drop out of treatment, it's often too late to re-engage them. So in more recent years, people have become invested in figuring out other ways to measure engagement in treatment so that we can intervene before someone drops out and it's completely too late. So again, attendance, that's been an indicator of engagement. That's relatively easy to measure, right? The person's there or they're not there. But we know that sometimes even when a youth is in treatment, in the room or on the Zoom with you, they may not fully be engaged and benefiting. So recent conceptual models include other dimensions of engagement, such as the REACH model, which was proposed by Kim Becker and colleagues. So they really conceptualized engagement as a multidimensional and transactional process in which various dimensions of engagement influence each other over time. And they found that you can actually distill down engagement in 5 categories or 5 dimensions here. And they found that in the literature, these were consistent indicators of engagement across studies. So just really briefly, relationship. We know that the therapeutic relationship and therapeutic alliance has long been held up as a gold standard of a way of engaging people in treatment. Therapeutic alliance is really critical. especially for youth. And so getting youth who might not even be invested in treatment to keep coming back when they don't perceive a problem is hard. I think I've dealt with that myself. I think we all have. And if a relationship can be established with a provider that fosters a lot of trust and buy-in, youth are more likely to continue showing up to treatment and eventually learning skills that can help them with their problem. Expectancy can be defined as the expectation that treatment will be helpful, as well as a youth's belief in their ability to successfully participate in treatment. When they have realistic expectations about treatment and the treatment process, they're more likely to be engaged and thus have better outcomes. We have attendance in there because, again, attendance, it doesn't capture everything about engagement on its own, but it is an important indicator of whether someone's going to continue in treatment or not. Clarity encompasses an individual's understanding of the treatment rationale, the approach, the structure, goals, and the role of themselves as an active agent in treatment, as well as what they can expect from the therapist. And then homework, we think about not just an individual completing homework between sessions, but also how engaged they are in activities in session. So they're in and out of session participation in treatment activities. And we know that completing homework between sessions has long been recognized as a means of facilitating skill acquisition and also allowing generalizability of skills to settings outside of the therapy room. So that framework was proposed based on the literature here in the West, largely in the US, and we know less about engagement in LMICs. And this study with Pride offered an opportunity for learning. So there are a couple of reasons for this information gap. Overall, there are just fewer studies that have been conducted in LMICs, although that's changing, which is awesome. Again, the engagement really has been defined in different ways across the literature, and it's typically not measured in multiple domains. But this study offered an opportunity to add to the evidence base of studies in LMICs using this clear definition of engagement and evaluating engagement in multiple dimensions. So the aims of this specific study were to characterize barriers and facilitators of engagement from both provider and youth perspectives in the Step 2 intervention in the clinical case series, and then to evaluate the overall acceptability, feasibility, and fit of treatment, again, from both provider and youth perspectives, as we think that if something is engageable, if it's feasible, and it fits the culture, it's going to be more engaging on both ends. Just a brief snapshot of our provider participants. We had some providers delivering services in Goa and some in Delhi, around 30 years old, with about 8 years of clinical experience. And they were experienced in delivering services across multiple settings. 2 of them had masters, 2 of them had their PhDs, and 1 was below a master's level, but had a lot of experience working in Sangat, which is the NGO with whom we worked on this study. So she was a relatively experienced provider. Our youth participants were referred for the 3 problems identified. They were referred for anxiety. Oops, I think we can go to the next slide. Yeah, anxiety, depression, or conduct problems, 8th to 12th grade. And they had to demonstrate partial or complete non-response on the strength and difficulties questionnaire at the Step 1 outcome assessment. And you can see the cutoff scores there for both total difficulties and impact. Then to take another look at our youth participants. So you can see in the overall sample broken down by gender, and then Goa versus Delhi. These are the youth who we ended up interviewing at the end of treatment. You can see that they opted to conduct their interviews kind of split between English, Hindi, and Konkani, which is one of the languages widely spoken in Goa. So the main measures for this study were semi-structured interviews. So we had a semi-structured provider interview that was adapted from previous qualitative research with providers and LMICs, and it was developed in close collaboration with the study team to make sure that it would fit the context and be worded appropriately for the workforce. And then the semi-structured youth interview was based on earlier versions of an interview used in Pride research. So it had been used in the field and found to be effective and useful. So we had our interviews conducted by researchers on the study across the 2 sites, and the interviews were translated and transcribed by a professional Delhi-based agency. We also went through an extensive checking process with members of the study team to make sure that the interviews had been translated accurately. I developed a coding system based on the interview guides, and then I trained undergraduate RAs in the coding framework. We coded gold standard transcripts, and codes were allowed to arise throughout this process. So we kind of used a mixed inductive, deductive approach to coding, and we resolved all discrepancies before any final codes were applied. And once all student and provider transcripts were coded, myself and the postdoc on the study at the time synthesized the codes from both provider and youth interviews separately into categories, themes, and sub-themes using qualitative thematic analysis. So we independently reviewed excerpts that had been coded, identified the key themes, and then met to compare, discuss, and decide on the final themes for inclusion. And then finally, I reorganized some of those themes into the reach dimensions when they fit to see if this framework actually did map onto barriers and facilitators of engagement. So here's some results. This slide is overwhelming, and I'm going to get more into these results as we walk through them in the context of the reach framework. But this is just to show that we found a number of facilitators to treatment engagement and barriers. And then we also found that a lot of youth were reporting on the functional impact of the intervention on their lives, and they offered recommendations for improving the intervention for implementation. Provider themes also, I'll kind of show you the overview before I reorganize them into the reach framework. So again, there are a number of facilitators to treatment engagement. They identified barriers, and then providers reported a lot on their experience with training and supervision, as well as some challenges that came up related to the complexity of the intervention. So I am going to touch on those as well. Even though they fell outside the reach framework, I think they do have important implications for engagement. So now I'll walk through these results going through the reach domains. So R for relationship. So results from the study are aligned with previous research demonstrating the power of having a really warm, caring, and collaborative relationship in the therapy context. So youth described providers' characteristics such as their smiles and the manner that they spoke as important to them feeling comfortable. They also really were interested and invested in providers if providers showed interest in their likes and dislikes and it felt personal to them. So I'm going to talk about each of these results from a provider and student perspective, either a barrier or facilitator. So this student was saying, I was used to my step one provider. And so when they stepped up from step one to step two, they had to change providers. And that's now been modified. So they get one provider throughout the whole stepped care intervention. But at the time, you can see how that would be concerning to students, especially if it was their first experience in therapy. So this student said, I was thinking, how will the step two provider behave with me? Whether she will understand my problem properly, or I'll be able to tell her my problem. But in the first session only, it was cleared. And whether or not she got angry, that was cleared by the second session. So you can just see how important it was for the student to feel like they were connected to their provider, and that stepping up and switching providers represented a barrier. And here a provider said that it was a facilitator for them to engage students by showing interest in their activities. So this provider went beyond the scope of the manual and really tried to spend time learning about them and taking time outside the session to read up on students' interests. And they noted that these students responded better when they took the time to really engage them in that way. So the next domain was expectancy. Again, that's the expectation that treatment will be helpful, and belief in the student's own ability to engage in treatment and participate and learn skills. So expectancy arose from a number of students who noted that their friends' experiences in earlier phases of the PRIDE study influenced them. So they said, this kid said, my friends were going first and they told me to go. And they, the counselor, will sort my problems. I was like, will they really do it? I was thinking if they would understand my problems because they were adults. So then I said, I will also try. And I went for it. So a number of students mentioned that their friends were really influential in them engaging in treatment. I think this was a little bit surprising, even though there's a lot of literature showing the importance of peer influence. There's also this thought that the stigma around mental health services, especially in LMICs, can be a barrier. And people thought that students would not want to be discussing their treatment experiences with their peers. So some of that came up, but there was a lot more about students encouraging their friends to go and really having a positive experience in that way. On the flip side, providers noted that if parents did not encourage their kids to go to treatment or reported negative expectations about treatment, that could prevent youth from engaging. So one provider had experience with one student in another school who was motivated to come, but didn't come because of her parents. So it just really shows the power that parents and peers have. And if we can destigmatize mental health treatment kind of in a universal prevention sort of way, that could have really powerful implications for youth engaging and benefiting from treatment. So next we have attendance, and I'm just going to show you a super simple pie chart here. There was a really big difference in attendance observed in the Goa clinical case series and the Delhi CCS. So that's what the phase of research we were focused on was a clinical case series here. So of the 16 youth who entered treatment in Goa, 14 completed. And in the Delhi CCS, it was the opposite. So of the 16 who entered, only 2 completed treatment. So this was a very stark example of something going wrong or something being different between these 2 sites, which offers a lot of opportunity for us to dig deeper and figure out what happened and how to make it better. So I'll tell you what it was. It's that in the Delhi CCS, while services were being delivered in school, partway through the year, something changed with the school administration, and we had to shift our services to an offsite clinic. So students were not able to see their counselors in school. They had to actually leave. And that really was a major barrier for students, especially as the end of the school year approached and it got hot. I don't know who's been to India, but it gets pretty hot there at the end of the school year. It was hard for students to leave and walk sometimes very far to their sessions. So we can see that the provider stated that the ease of access could have been a reason for students being more engaged in the Goa school. So that ease of access is a facilitator, lack of ease of access is a barrier. But also students said that there were challenges related to this being in school that presented a barrier. So this student said, now I'm going to take my name off from the counselor sessions because I'm in class 10th and I want to concentrate on my studies. Yes, I'm in 10th standard and studies are tough. I don't want to take risk as students often get failure in this class. So even though the services were being delivered in school, kids still had to miss classes. And especially as students got older, and academic demands increased, they found it harder to miss even one 25 or 35-minute period a week to attend counseling sessions. So this really speaks to the importance of, being flexible in the dosing and delivery of an intervention, especially around exam periods and holidays, and getting buy-in from the administration at every level of the school in which services are being implemented. So clarity, again, encompasses an individual's understanding of why they're in treatment, what it's going to look like, what their goals are. And youth reported that when they felt clear about the applicability of skills to their problems, they were happy and they were engaged. So this student realized that her problem was that there was unhappy guessing and self-blaming. So she says it was like, Miss, the counselor told me to try out these exercises and then see. So I tried and I made some of my classmates as friends. And then later she asked me, how am I feeling now? And I said, I'm feeling good. The great thing about her was that she would give me examples based on my own life. So students were really clear about the purpose of why they were doing what they were doing. And that kept them coming back to learn and practice more. So on the flip side, providers reported that if it took a while for students to get to their main concern, for example, they were going through psychoed, engagement, relaxation, say they felt that wasn't applicable to them, they didn't know why they were there, they would lose interest. So this provider suggests really telling the student at the outset that there's going to be some time in the beginning of treatment where we're learning a few things that you might not understand immediately why, and then it's up to the provider to help them make that connection. But this was a reason that this provider thought could be what led to dropout, lack of clarity. And then finally, homework. Not that many students reported on their experience with homework, but we saw that students who brought the skills outside to the home had a pretty positive experience, and a lot of them enjoyed sharing the skills they learned with their friends and family. So this one student says that she shared with her sisters was she shared deep muscle relaxation and deep breathing. So we did nicely. The three sisters did nicely. We were sitting in triangle shape and did this exercise. If there's some new exercise, we like to share our things. And that's pretty cool because it's kind of this natural diffusion of innovation and skills. So that was pretty cool to see that when students liked what they were doing and it felt engaging and relevant, they brought it outside and taught other kids who might benefit as well. And so providers reported that there still needed to be some improvements made to the homework and the handouts. They felt that the handouts were still very westernized, requiring kids to do a lot of writing, which wasn't a good fit for the setting. And I think we've probably all experienced youth having a hard time and adults having a hard time completing homework here in the therapy context. So this was helpful feedback from providers to help us improve what was on offer and to make it a better fit for the context and culture. And then briefly, there were some themes for both providers and students that fell outside of the reach domains. But I think they're important to highlight because students talked about the functional impact that the intervention had on their lives. This person shared that her life was changed. I was angry at first, friends weren't talking, but after doing counseling, my anger came down and people noticed and people got closer to her friends and family and teachers. I think this is just a really nice example of when students stay in treatment and engage in treatment, they can benefit in a way that really changes kind of their suffering and what they're going through. However, they also offered themes for improvement. So this student said how counselor called students in the class loudly should be changed. So sometimes providers would go to the classroom and kind of say, oh, can I see so-and-so? And students felt that that should be a more discreet process. So even though some students were sharing the skills they learned and talking about it with friends, that was really different for them than being called in front of a class of 35, 40 kids to leave and come to counseling. So that's something that we can do better at. There are also some additional provider themes. So providers shared that sometimes it felt punitive in terms of the supervision they were receiving. So sometimes they were feeling like they weren't getting constructive feedback and didn't know how to actually improve the therapy that they were delivering. So this was hard feedback to get, but it was also super important because we want providers to feel supported, especially when they're learning something new, and especially when it's an intervention that's not super duper easy to learn because of the complexity of addressing multiple problems at once. So similarly, this provider said, I feel like at some point in time, I was trying to cater a lot to the manualized treatment, which makes you tend to forget that you've actually learned a lot of counseling skills and you just forget. So this is something that I hope to focus on further in research, just also really helping providers feel confident in their skills, reminding them that those foundational skills of rapport building, all of that is so important, sometimes maybe even more so than the skills that you're teaching. So how do you balance that tension between managing a complex treatment, coping with your own anxieties about showing up in the perfect way, and helping providers know that it makes sense that it's hard at first and it's not just them. And so that gets to our discussion, which is that youth and providers, despite some of these challenges I just highlighted, they largely perceive the treatment to be engaging, acceptable, and appropriate for the context. The differences in engagement and retention that we saw between the Goa and Delhi sites may have been driven by accessibility barriers. We're not sure, but it's very possible. We saw that the therapeutic relationship emerged as a key facilitator. And I think that's great because it really offers an opportunity to bolster that and those foundational skills in a way that doesn't demand learning a bunch of different skills, a bunch of different things to target different problems. The therapeutic relationship alone can be so powerful and shouldn't be overlooked. And then finally, balancing the complexity of the intervention with its utility was a prominent challenge for providers, but it did improve over time and as they grew in their confidence and their ability to deliver the treatment. So in the future, we really want to look at this treatment in a larger sample size, which is happening right now. So step 2 has been refined based on some of this feedback and other pilot studies that have been conducted. So hopefully we'll have more outcomes to look at, especially in Delhi, since we didn't really have a ton of Delhi data because of the high rate of dropout. So those were some of our limitations, but we're already working on addressing them. And we also think it'll be important to use assessments to gather more information about the workforce and design the trainings to better meet their needs. So even though these providers had, a background in mental health, some of them had masters, some of them had PhDs, there were still gaps in their training and knowledge, as all of us have. So we want to next time at the outset, do a more thorough assessment of their needs and meet them where they are, and then communicate the expected developmental pathways to providers so they don't feel like they're burned out or they're failing. We want them to know it's going to be hard and they can do it with our support. So in summary, we know that improving mental health is paramount, especially for youth and adolescents who are really at a vulnerable stage in their life, and especially in LMICs where resources are limited. This study shows that we can make a real difference in youth's lives through a protocol that's been specifically designed to engage them in a certain context with folks whose on the ground knowledge and familiarity with the culture is high. We also know that we should develop perhaps a protocol for providers that has a stepped care approach too. So this intervention had a stepped care approach for youth, but maybe we also need to meet providers where they're at by developing a training protocol that kind of meets them where they are and then pushes them to the next level in a developmentally appropriate way and into a version they can manage as they get more experience. And then finally, there really needs to be this global local exchange, which I'm preaching to the choir here, since this is the global local kind of center. But as we continue to increase our focus on context and culture, we should make sure that it's not a one-way flow from one part of the world to another. It really should be a continuous and dynamic exchange of information, research, local knowledge and wisdom to facilitate that exchange and make sure that we're learning from all of us together. So that is all. Thank you so much for your time and attention and just the opportunity.
Oh, that was great. Thank you so much. So everybody's quiet, but we have time for questions. And people are welcome to turn on their videos as well. We can, see you.
I always have a question, so I'm happy to start.
Yeah.
Resham, you had mentioned in sort of the assessment component that something about the worksheets was felt to be, I think the term you used was too Western. And so I'm curious if that was explored a little bit further, what exactly about the worksheets was felt to be that way, in part because just like you said, I find that it's really hit or miss whether worksheets are used in any context. And so I think that it's always helpful to think about what's working for people and what isn't. And so what did they find that was not super helpful?
That's a great question. And I think we've all been there as providers trying to, it's like pulling teeth, trying to get people to complete worksheets between sessions. What they were referring to there was that the worksheet still required a lot of writing. And literacy rates were really variable across the settings and across just within the student population. So some students had a much harder time reading and writing. So we were trying to incorporate graphics, but we still had some worksheets that asked students to write down, for example, what they were doing for BA. So that's what they felt. It also was felt that needing to take something home where there might be limited light, limited electricity, having to kind of navigate all those challenges from a logistical perspective also showed that this wasn't the best fit for the context. But again, I think that it's important to recognize that some of those same challenges arise here. And how can we reduce barriers to homework completion and make it something that's going to be relevant?
As a follow-up, I'm curious if any providers attempted to change that process in real time. Like I'm imagining if folks have a cell phone that has some sort of recording capability, if they could do some of it just orally and play it back to their therapist.
Ooh, I love that idea. I think the issue is that a lot of people don't have access to that sort of technology yet. So there is a digital component of the Pride intervention, but it has to be given to students on like study or research supplied technology. And even then we were finding that students still wanted to have interaction with an in-person counselor. So we're kind of exploring a hybrid model of digital mental health delivery. But I hope that, as cell phone use becomes more widespread across the world, we can incorporate technology to help reduce these barriers.
Now, do you, I may have missed this, but was there any type of assessment or interaction with the parents that where you gather data about the home environment? And
that's a great question. We got parent consent. So all parents had to consent for their children's participation, and then youth provided assent as well. I don't know. I think in this phase of the research, we didn't collect a ton of data on the home life, but I think it would be really, really important and super interesting to do because, these were students, even in Goa, which is kind of thought to be more of a highly resourced state than what we're seeing in Delhi. There were students who were coming from all over the country. A lot of their parents were domestic workers. They were reporting a lot of challenges like domestic violence in the home, alcoholism, things like that. So there was a lot going on at home that I think contributed to their distress. And if we were able to engage parents, that would be wonderful. And we know that a lot of them, again, were like day wage laborers for whom missing any sort of work could have a really significant negative impact on their situation.
So Resham, I have a question. If you had to give advice to someone who's doing research overseas, I know that from your research, you have some learning lessons, but some more personal learning lessons. And I know I'm addressing here a group of global researchers, but I'm curious. I see, for example, the problem with the evidence-based practices and having to stick to the format of them, that they are a problem here too. Among many, for example, Latinx communities, that's a problem. Also the homework, too much use of the verbal descriptions and long homeworks, that doesn't work for them. So, okay, so that's one observation I made while you were presenting, but what would be some of the learning lessons?
I think just, treating everyone that you work with like a person who has something valuable to contribute and share. And, I think that there is this practice, like there's a lot of colonialist roots in global mental health research. And some of the structures in various countries, including like in India, there's a real hierarchy of, degree and background and who can say what based on their training and their degree. But I really found that everyone had something valuable to contribute, from someone who's like a lay worker to someone who has a PhD from the best university in Delhi. So I think really just being open and humble and listening to people and checking back in with them to make sure you understood, like that's the best way to go about that sort of research, when you really are like, it's an honor to be able to even be invited to learn from people who know much more than you in these settings and to offer a little bit of what you might have to share.
Thank you.
I have a question as well, if that's okay. Thanks, Resham, for your presentation. It was very exciting. And I've been doing some task sharing based work in India as well with Sangat in rural communities in Madhya Pradesh. And your presentation made me think about rural communities and task sharing and children going to school, or maybe who are not going to school, and how this could be integrated in communities, if at all, through this program or through other programs. And especially if you think about scaling up, what kind of challenges you may anticipate, or maybe factors that might facilitate the integration of these kinds of programs in the community for children?
That's a great question. And I'd love to hear more about your research too and how that's going. Yeah, I think rural, as hard as it is in some places in India with cities being big and bustling and the challenges that brings with it, rural communities have it a lot harder, right? So of those psychiatrists or mental health care workers that I was referencing in the beginning, most of them are concentrated in cities, leaving that gap much larger in rural areas. So I thought a lot about this when I was in Goa. And I think that having a more universal prevention sort of program that starts really young and that can target not just youth engaging in services, but also their parents to reduce stigma, to make it much more easy to talk about mental health and treatment, that's one way to go. And I also think that doing youth group interventions presents an opportunity, again, to reach the maximum number of kids in need of services and to give skills even to students who aren't in distress, like who couldn't benefit from learning relaxation and problem solving. Right. And I think that it was exciting to hear youth share that they shared their skills with their friends and that they took them even into the home. So I think a lot of the time we thought, no, we shouldn't do group interventions. There's stigma. No one will be comfortable. But actually, I think that youth, maybe it's changed, but they seem to be pretty open to sharing with and learning from each other. So I'd love to see more work around group interventions for children and adolescents.
And just one more question to follow up on that. Could you speak more about the providers who were involved in the intervention? So you mentioned some were like PhD level, master's level. Were they paid? How were they remunerated for their services?
Well, so it was kind of unique because they're Sangat staff. So they've kind of worked their way up, and some of them are in research capacities and clinical capacities. So it's a little hard to say that this intervention would be very easily utilized by people with less experience. I think we really would need to bolster the training because these were folks who have specialized degrees and had familiarity with working in settings like this before. So they came in with a lot of experience, yet they still face challenges. So I think for me, what I realized is that the bottleneck really is around supervision, right? So we can train a lot of providers to effectively deliver services, but when you have those complex clinical cases, that's when you really want support from someone who has more highly specialized training. So that's something else that I'm looking forward to figuring out, like, how do you solve that? You can't just have one supervisor overseeing hundreds or thousands of lay counselors if it gets scaled up in the way that we'd like it to be.
I have another question. On behalf of our trainees who are on the call, I'm just curious if you could say a 1-minute version of how did you get on this grant? How did you get connected to the people that you're working with?
That's a great question. Well, actually, so I'd long been interested in global mental health and knew that's something that I wanted to focus my career on. And when I interviewed for my PhD programs back in, when was it, February 2015, I interviewed with Dr. Bruce Torpeda at UCLA, and he hadn't done much global mental health work before, but he'd started working with Dr. Vikram Patel on this grant to help develop the Step 2 component. And he mentioned it when I interviewed with him that could be something I would be involved in. And so that was one of the really main factors that helped me choose UCLA, because I could just see a fit there. And he also conducts a lot of really exciting research in children's community mental health settings here in the US. So I was so fortunate to work with him and also Anna Lau with vulnerable youth and families in the context of LA County, and to see what can we take from lesson learned here and bring them there. And so I think being, knowing what you want, but also being open to seeing how other types of research and opportunities can complement that is always a good way to go into new spaces and working with new people.
Wonderful. Any other questions? We got time for one more question, maybe? One of our trainees, maybe?
Yeah, I'm Herman. I'm a second-year resident at Boston University, and I'm originally from Colombia. Moving to the US, there's always that thought of like, how to leave in one place and do research somewhere else. You know, like, do I have to leave where I do research? Does it impact how much I can do and how, and like the outreach that I can have? What has your experience been kind of like doing research over the distance and kind of having resources here to apply there?
Yeah, that's such an important question, because I think I've always been very cognizant of the fact that I don't want to be someone who's a global mental health researcher and that I'm just going to pop into different countries and, you know, do research that's going to feel cool to me, but that doesn't really create sustainable community partnerships and benefit the actual people there. So I think for me, the way I've been thinking about it is that I'm really invested in creating sustainable systems of education and training and understanding, like, how can we make it so that people don't need to be popping in and starting from the ground up or from scratch in some ways, but how can you actually like create schools and like internship or residency training programs that are going to be staffed and led by experts who've been maybe given some knowledge or support by you, but with the aim of you being able to pull back. But I hear that you're from two places, you know, and so you're kind of straddling both worlds, which also has a lot of value and benefit. And I think that what's been interesting to see is how COVID's changed things. Like, this sort of meeting that we're having is normal now. And in the early stages of Pride development, you know, I'd be on a Skype call with a couple of people, and it was just a very different time. All of a sudden, this seems very normal and easy. So I think hopefully we can keep some of the ease of access going with the improvements in technology across time zones and countries. But yeah, just thinking about the long-term sustainability of your involvement, whether you're here or there, is a good way to approach it.
Great, thank you very much.
Yeah.
So I think that's it. Sinead, are you there? First, we want to thank you for joining us this evening. It's a fantastic talk, and we need to meet again. Like a dozen more ideas just came to my
Awesome.
in my head as you were talking. So so thank you, and people can pause thing and all that.